So in chapter 35, we had kind of, like I said, that top down and that bird's eye view of health insurance for employers in general. So what we're going to talk about in chapter 36 is kind of what we call a traditional group plan. So a traditional group health plan, right? So again, just to kind of underline the importance of this. So health insurance is the most common employee benefit. It's more likely that we'll see an employer offer health insurance than it is kind of some of these retirement plans that we've looked at. Okay, and this is mostly because of need, and there are some tax benefits for employers and employees as well. Okay? Now, I want to remind you guys of some of the advantages we would see of group health plans from an insurance market perspective. Okay, the first and is that we see reduced adverse selection. Okay? Why is this? Well, it's unlikely that people are, an entire group of employees, let's say you have 100 employees, it's unlikely that all 100 of them went to this job, took this job just to get health insurance. Okay. Could it be that there's a non-zero amount, a positive amount that did that? Yes. All 100? Not likely. So we're limiting some adverse selection here. Whereas individuals who are going on, let's say, the health insurance marketplaces looking for health insurance, that's literally what they are doing. That doesn't mean it's adverse selection, but they are choosing just to get health insurance. But here we have some mitigation of adverse selection because more than likely they want the job because they want the job. And the health insurance is a perk. Also, we have 100 employees. Well, that sounds like a pretty good start to an insurance pool to me. So it's already kind of pooled. Adverse selection is not quite as strong on average. And then additionally, for the employee side, or the people in the pool, it's rare that there's any evidence of insurability required. That doesn't mean that you won't ask questions about, do you smoke or something like that. But more traditional sense, there's no individual evidence of insurability required. And these are kind of the three primary reasons that, if I were to compare, say you get a new job and we look at your health insurance plan through your job, and then you go and try to find something similar on your own, you're going to struggle. It's probably going to be impossible. Okay, even if you're young and healthy, and I hope you are, but you will still struggle to find a similar plan. Why? Because you're not getting any of these advantages, and some of these advantages are good for you, but they're good for the market, meaning that the premiums will be low, which is also good for you. Now, we kind of have two types of plans broadly here. We have our prepaid plans and what's sometimes referred to as postpaid plans. Okay, I don't use this verbiage frequently. Okay. A prepaid would be like your standard HMO. Postpaid, FSAs definitely. HSAs can be that way, but it's more common for an HSA just to be an actual account and you have a debit card. And you use your HSA debit card. Okay, so you're kind of paying in prior to that, but you're paying after services are rendered. Okay. But these are kind of the two broad types. Now, there aren't necessarily a lot of benefits that come just from them being prepaid versus postpaid. So I want to go through these four kind of big aspects of plan design and things that we have to keep in mind. There are three broader types, and then there are some changes. Again, we're going to see the ACA essential benefits. So we have to cover that. Okay? So the first plan, and a little bit, archaic at this time, is your basic plan. What do basic plans cover? If you're seeing a doctor, i.e. inpatient, that's often covered. So inpatient services are covered. In hospital physician visits, again, this is technically inpatient, meaning that you're meeting the doctor. Outpatient will be that you might not see the doctor. Like an outpatient surgery, you might not meet the doctor. Okay, they'll knock you out before they do the surgery. And you might not actually consult with the doctor or the surgeon. Okay? But inpatient traditionally means you meet the doctor. So she or he comes and talks to you. And then you do get surgical fees. Okay? Not all outpatient services, but surgical fees. The exclusion home and office visits are not always covered. Okay? Now, a major medical plan is different. and it's kind of, covering in supplement to a basic plan. Okay. So we get routine checkups, we get those outpatient kind of, meetings. And there are some basic plans that would kind of cross over into a major medical plan and vice versa. But that Venn diagram, those two circles, it's a very thin sliver that marries the two. Okay, very thin. These plans can be used paired together. If you want to just kind of pick and choose. But the more common way to do it is just to have what's called a comprehensive plan. Most plans are comprehensive. Okay, so the most common plans, they combine all these services from a basic and a major medical. And when you look at it, you might say, well, there's a lot missing in that basic plan. There's a lot missing in the major medical plan. Why wouldn't I combine the two? Well, there could be cost savings. Okay, or it could be that you get the basic plan and then offer an HSA in a cafeteria setup. Okay, so it's not to say that they're not useless, not useful. They are. Okay, but oftentimes, we find there's more satisfaction with comprehensive plans, if do nothing else to the fact that comprehensive sounds better than basic. Now, here's the list of the ACA essential benefits. Okay, again, in Chapter 35, it doesn't dive into it as much. It brings it back up in Chapter 36. But these plans must still cover these essential benefits. Prior to 2010, very few of these were required. Okay? So ambulatory and emergency services, hospitalization, those were usually standard. Some that are relatively new, depending on the plan, maternity and newborn care. That's the example I gave in the last chapter. So to me, I wouldn't see a need for that. But it's going to be included in my plan. Okay, and it's a bummer for me, I'm paying for it, but could lower overall cost, I guess, or at least provide maternity and newborn care to those who need it. Okay, it's cheaper for them. New would be the mental health and substance misuse disorder. It has to be covered as well. And dental and vision were often offered as like ancillary packages. So this wasn't too new, except for the fact that to call it comprehensive, now you have to also include dental and vision. In my time working with it, I did not see many employers that didn't offer dental and vision. Sometimes it would be opt-in, sometimes it would be opt-out. So this wasn't too much of a game changer. Okay? Not too much of a game changer. Same thing with lab services. Okay? But again, the big kind of disruptors, that sounds too negative, but the big changes would be maternity, newborn, and then mental health and substance misuse and rehab. Okay? Those are the big changes. All right, let's talk about the basic structure of each of these. All right, so employees and employers both need to keep in mind these common plan mechanics. Things that you've probably definitely covered up until this point. You have deductibles, co-insurance, and really, this is somewhat new, the out-of-pocket limits. I say somewhat new again, relatively speaking, that's about a decade. Prior to the Affordable Care Act, not all plans had out-of-pocket limits and essentially unlimited coverage, but now they must. So there can't be a lifetime maximum, okay? And there must be out-of-pocket limits. Now, these are kind of designed, especially deductibles and co-insurance, to reduce moral hazard. If you have no deductible, no co-insurance, what's going to stop me from just going to hang out with my doctor? She's always very nice. Okay, just go hang out with her. It's only costing me time, but I get to talk to somebody and I don't have to pay anything for it. Right? That can obviously increase prices, especially when any claim has a fixed cost. So every claim is going to have a fixed cost to go through the system. Okay? Whether it was actually a $5 claim or a $5,000 or $500,000 claim, there's a fixed pipeline cost to pushing that through the system, meaning that it's horribly inefficient, okay, to not try to mitigate or lessen those $5, $10, $15 claims. Okay? So it helps the market, helps the pool. So deductible, quick reminder here, it's the amount that the policyholder is going to have to pay before any type of coverage or benefit kicks in. And we don't see this in liability contracts, we don't see this in life contracts, but health insurance and property contracts, we see this. Quick example in health insurance, because that's what we're talking about today. If it's $2,000 deductible with no co-insurance, we see a $3,000 loss. The insured is going to pay $2,000. The insurance company pays $1,000. Now, this is not a per loss. This is an aggregate deductible. So per loss or per item means that you're going to pay that deductible for every single time you suffer a loss. That would be akin to your personal auto policy. So if you have a $500 personal auto policy deductible, every time you suffer a loss, you're paying $500 every time. Health insurance, no. You get up to this in the policy period, usually a year, and you don't pay anything else unless there's co-insurance. And there's almost always co-insurance. Okay. So these would be all calls, or you're probably more familiar with the word aggregate deductible. Okay. Other than straight deductible or per calls. So these are all calls. Now, deductibles in health insurance, so keep in mind that's what we're talking about here, have increased significantly in the past 10 years. Not as much from 2013, 2014 to now, okay, but still. So it's increased, but not necessarily an increasing rate anymore. This could be potentially correlated or related, I won't say caused by, but potentially related to the actual increasing cost of what needs to be covered. So for any insurance market, if the average car price goes up, then all other things constant, auto policy premiums are also going to go up. Okay, so if the underlying loss exposure, the severity of that loss exposure increases, then of course you would expect the premiums to increase. Okay, increased coverage and benefits, same thing. We hold everything constant, provide more coverage. Okay, lower deductibles could be lower out-of-pocket limits, or actually having out-of-pocket limits. That's more coverage, it's more expensive, premiums go up. Okay. There are also underwriting limitations. If I can no longer write based on sex, or they're male or female, if I can't underwrite on that, or I can't rate based on that, then that's greatly limited my ability to underwrite. Okay. And in fact, in individual markets, we can only underwrite based on age, whether or not you smoke, and where you live. So those are the three underwriting classifications, which is very limited. Now, why is that a good thing? If we look at the market for the individual and those who really need it, it could be very beneficial. But the prices would go up because underwriting is limited. Okay. Now, co-insurance. So this is after the deductible. So for health insurance, not property. For health insurance, this is after the deductible, and it's essentially a cost sharing. We often see a 20%. You would see it listed as 80-20, meaning that the insurance company pays 80% after the deductible, and you, the policyholder, would pay 20%. Sometimes you see 75-25. 80-20 is very, very common, the most common. Give you a quick example here. Have a $2,000 deductible, 20% co-insurance, and we have a $3,000 covered loss. Well, policyholder still pays that first $2,000, but then they only pay 20% of that remaining $1,000. So a total of $2,200. Company pays the rest. Now, maximum coverage limits. So traditionally plans didn't really have this, okay, but there was a limitation on it, okay, and it wasn't something that was crazy for insurance contracts. A lot of insurance contracts have a maximum amount they pay out. If you have a $50,000 vehicle that's insured, why not cap the payout at $50,000, right? So it's not unusual, but because of the cost on the tail ends of losses, so if we recall loss distributions based on your prior classes, loss distributions are rarely normal distributions. They tend to have a long tail, and they're truncated at 0. You don't generally have a negative loss. But on that tail end, the costs are pretty high. In fact, there are some estimates that say, depending on the type of terminal care, and I put cost here because healthcare accounting is interesting, and it could be different based on if you're in network or out of network or paying in cash or health insurance is paying. So cost is in quotations here, but it could be as much as $10,000 per day for end of life or terminal care. It's very expensive, okay? So it's like, all right, maybe we should put these caps on it because when people really do need it, it's not paying out what they need. Okay, so that was the argument for it, and were I in that situation, I could absolutely understand it. Okay? So out-of-pocket expenses, though, this is that cap. So the $7,900 for 2019 or $8,000 for 2020. Includes just deductible and co-insurance. Doesn't include your premiums. Bummer, right? Be nice if it were that, but does not include the premiums you're paying in. You're paying that for the coverage. Okay, that's already factored in. So example here, we had that same $2,000 deductible, that should say 20%, not $20%. 20% co-insurance, $5,000 out of pocket, and then we say there's a $20,000 loss. Okay, could be a not in the emergency room. Okay, without the limit, what would happen? The policyholder would pay $2,000 plus 20% of the remaining $8,000. But there's an out-of-pocket cap of $5,000. So at this loss for this year, this policy period, they hit the $5,000 and they're done. Any other covered loss ex post this is paid by the insurance company until it resets for the next policy period. Okay, and these are just quick reminders. You'll probably see some, I would say short kind of multiple choice type questions based on deductibles and co-insurance. I'm assuming you probably already had them, but just in case, it's good to kind of keep in mind how they work. Okay. All right, so with all this being said, look at kind of the cost aspects of things. How do we fund this? Okay, how do we fund this? And we'll go through each of these, but basically we could buy it, we could do a nonprofit, we could self-insure, or we could let HMOs and or PPOs. Okay, so for commercial contracts, this is just buying a group health plan, let's say from Aetna. Okay, now Aetna does also offer Blue Cross Blue Shield. They do also have HMOs and PPOs. Okay, but if you just buy a standard group insurance claim, okay, that's a commercial contract. Okay. Now, the kind of, I guess, market play effect here, which is pretty peculiar, is that the pricing isn't always on the employee, or in this case, the insured, the policyholder side. Okay, it's between the insurer and the provider. So reimbursement here, so this is kind of that ex post, the reimbursement is limited to what's known as UCR, usual, customary, and reasonable claims. So if we go and look and see the average MRI is about $2,500, and we're the health insurer or the employer sees this, and we see that a hospital is charging $5,000, we might dispute that. Okay, we might want to know why that's happening. Could be a valid reason. I mean, MRI machines are very expensive. CT scans as well. So it's not on the employee to kind of cost check this. And in fact, one thing that we can often see with HSA plans, because it's coming out of someone's savings account, we might see a little less moral hazard because they see their money going out. Where here, it's kind of in this black box. They'll get the bill and see a $5,000 charge for an MRI and say, well, I'm never going to pay that. Well, they go to the ER and get a $20,000 bill. I'm never going to pay that, and they just let the insurance company, hash it out. So there's some problems with cost insulation here too. Okay. Now, the claims here, to keep in mind from the employer perspective, they're going to reflect any risk charge. Okay. This is the rate. This is kind of an actuarial standpoint. So the rate making. Also expected claims, admin expenses or commissions for agents or brokers. Any premium taxes that must be paid, this could be going into guarantee funds or something like that if you're in New York. And then investments on premiums. Okay. So that's kind of a return. Okay. So average health insurer profits for 2020 were about 2%. About 2% profits. That's including investments and underwriting. Okay, so pretty small. Better than the average restaurant, I guess. Razor thin margins there. Now, these can be adjusted, and often are, based on the employer's loss experiences. Now, so what about a nonprofit or not-for-profit option? Well, that would be Blue Cross Blue Shield. Traditionally, these are actually separate entities. And it's not necessarily that it's a true type of insurance. It just, Blue Cross Blue Shield is more, you can think of it as more of a designation. Okay. Meaning that money has to just go back to the group. You could look at it as almost like a mutual. Okay. Rarely do these involve insurers. That's changing now. okay? But rarely do these involve insurers, okay? Um, the reason we see more insurers is because, unfortunately, even with these non-for-profit plans, the healthcare costs were pretty high. Um, pretty high. So people in the group were not able to pay them. So then you needed insurance, people pool their premiums to pay for losses of individuals in the group, but not the entire group. Okay, so pool and spread. Now, these often deal with kind of this idea of not necessarily in network, but participating networks or providers. Okay. Why? Well, they agree to rates for services. So they agree, all right, we'll pay, or we'll charge $2,500 for an MRI, not a penny more. So there's some good to be had out of that. Now, so these are nonprofit organizations. They're often geographic based. So Anthem Blue Cross Blue Shield of Indiana is an example. It's not uncommon to see these be kind of based on geography. Okay, it could be at the southeast, but it's usually a state. Okay. Now, the plan again is to keep costs low. There are some arguments. It's hard to show any of this to be fair, but there's some evidence and some arguments to say, all right, well, due to lack of actual competition across hospitals, so we see far more profits in hospitals, around 8% for profit hospitals, 4% for all hospitals, including nonprofits. So we see pretty good profit margins for hospitals. And we'll say, well, maybe there's not that much competition across hospitals. You could look at rural areas and say there's no competition because there's only one hospital. Okay, that one could make those arguments. Meaning, therefore, if we're setting that price for an MRI at $2,500, does it really cost $2,500 a pop to use that machine? It could, but doesn't. And hospitals are, if they're non-for-profit, they're businesses, and they need to be ran efficiently. If they're businesses, that's one opinion. So cost cutting is important. Increasing revenue is important. Okay. There's still some profit drive there too, but it can come with some efficiency. So that's just one kind of view on it here. Okay, so nothing's perfect. Now, what about self-funding? All right, this is a pretty wide, pretty broad way for an employer to offer insurance. It could be that they agree to pay out for certain services, or they agree to supplement their employees in purchasing a health insurance plan. So it could be that we will pay for 50% of your health insurance plan, whatever you may choose, whether it's on the exchanges or what have you. And that's about the only individual plan that you can usually find, but there you go. So that allows more choice. HMOs and PPOs kind of fit in this as well, so just keep in mind the difference is that PPOs are their preferred provider, but you can go outside that network for some coverage. They're going to be a little more expensive, but most people tend to prefer that. Okay? But HMOs and or PPOs, they're, again, these organizations, they offer broad, nearly complete coverage. It could also include insurers and providers, and Blue Cross Blue Shield would have this too. And it's really an alternative to traditional insurance, but it works in very, very much the same way. And in fact, when you think of HMO, most people think of, oh, that's health insurance. For all intents and purposes, it works in the same way. Okay, and again, we have a little more discussion on that in chapter 35, but I just do want to mention that that's one way that we can think about funding. And this would be cheaper again than a PPO, but would provide less choice for the employees. Okay. Are there any questions on chapter 36 here, group health plans? Any questions?